respect and independence. But volunteerism has been one of the things that have suffered from the current isolation and quarantine rules. And then finally, finances. We know that many older adults themselves have financial challenges. There have been some modest adjustments to pensions to offset this, but still the costs of perhaps arranging for transportation or delivery of goods or assistance in personal care, etc., which may now be increased because family members are not necessarily able to come in and help their older adult relative, means that there are even more financial challenges during this current period. Then there's the consequences themselves of being isolated in one's home and having limited opportunities to leave and limited opportunities to participate in any recreational social activities. We know that immobility is associated with problems of loss of muscle tone and mass. Approximately every day we spend in bed or just sitting is associated with 1% loss of muscle. If we're inactive, we're much more likely to see problems of frailty, potential negative consequences like falls, and also adverse outcomes from a number of diseases such as diabetes and cardiovascular disease. And then there's, of course, the mental stimulation effect of isolation or limited activity, which can result in low mood and even worsening of pre-existing cognitive problems. So when we talk about social isolation and loneliness, we tend to talk at social isolation as the objective, measurable, quantifiable aspect of the equation. In the sense we're talking about the individual having a low quantity or quality of interactions with others. Conversely, loneliness is a more subjective feeling. So individuals can actually have little social contact, and we would say are socially isolated, but may not feel lonely. Or conversely, they may have a rich social network and still perceive themselves as lonely. Let's look at some of the risk factors for social isolation and loneliness independent of COVID-19. Certainly, there's evidence that older adults with increasing age, particularly women, particularly those with low income, living in isolated rural areas, are more prone to be at risk for social isolation and loneliness. Individuals in congruent living settings, such as retirement homes and long-term care, are particularly challenged at this present moment in time. Within the facility themselves, many have limited access to a number of recreational activities they would have enjoyed in the past. Their ability to access families and friends limited to perhaps telephone calls or attempts at video conferencing. There's a number of medical risk factors. We know that individuals with chronic diseases, which are often associated with reduced mobility, may be more at risk for isolation and loneliness. Individuals with impaired sensation, so appreciation in terms of hearing or vision, are particularly vulnerable to problems of isolation and loneliness. Individuals with cognitive impairment, whether this is mild cognitive impairment or an actual dementia, are much more at risk of isolation than individuals without cognitive impairment. And then, of course, there's the social risk factors. If you are living alone, if you are living far from family, particularly when family can't visit during the current isolation rules, if you have a lack of transportation or friends, or maybe friends who've aged and in fact have died themselves. You may actually be a caregiver yourself, although an older adult, of an elderly relative, and therefore become socially isolated because of that caregiving role. And then there's the possibility of significant life changes. Perhaps because of decline in mobility, individuals will change residence, perhaps move from their previous community to supposedly be nearer to family, but then perhaps find that they've isolated themselves from peers and their community. The loss of a spouse can always create problems of isolation, loneliness, and depression. And as individuals unfortunately decline in health and functional capacity, again, they're at risk of becoming socially isolated. So just to emphasize some of the negative effects of this isolation and loneliness, it's estimated that uh, loneliness and social isolation contribute to a 30% increase in risk of death and are roughly equivalent to the effects of someone who is a heavy smoker or morbidly obese in terms of impact on the individual's life expectancy. Certainly, as mentioned, individuals who are socially isolated or lonely are often less active, therefore less mobile, and more prone to muscle loss and problems of falls. There's a 2 to 3-fold increase in the risk of cardiovascular disease and other serious illnesses, and an increased risk of problems of malnutrition. There's a chicken and egg effect in terms of mental illness. So individuals who are depressed are more likely to be isolated. Conversely, people who are isolated are more likely to be depressed. So it can be difficult to tease out which is the precipitant and which is the outcome of the other. Certainly people with cognitive impairment, as I've mentioned, and individuals who are suffering reduced life satisfaction are much more likely to perceive themselves as lonely, irrespective of their social networks. There's an increased risk, as I think will be documented as we go through this conversation, that individuals who are isolated or lonely may suffer elder abuse, whether it's financial, whether it's social, or whether it's physical. We notice an increased use of health services by individuals with problems of isolation and loneliness. They're more likely to access the emergency room. They're more likely to access their physician if potentially possible. They have higher likelihood of hospital admission and longer lengths of stay, and unfortunately are more likely to end up in a long-term care setting. So let's talk about some of the various interventions that are described in the literature. And this table is taken from some work done by Gardner, who published a review of interventions in 2018. And she divided them into these 7 different categories of interventions. She talked about social facilitation, things such as social clubs, day programs, and chat rooms, which, based on the literature, do seem to be successful interventions, particularly if they involve an education or psychosocial focus. Therapeutic interventions, psychological therapies, things such as reminiscent group therapy, mindfulness, based interventions, and cognitive enhancement programs, which are usually led by health professionals, do seem to have some benefit, although it's difficult sometimes to tease out whether it's the psychological therapy or the effect of the group and the interactions within the group that results in the benefit. Increasingly, we're seeing examples of animal-based interventions, in particular the use of robotic dogs, or more recently, some of you may have read today in the Star an article about robotic cats, which have been used as therapeutic tools in congregate living settings to potentiate socialization and positive interactions. So they have been used effectively in long-term care and residential care settings. Physical activity itself does seem to help with social isolation and loneliness, and a variety of interventions have been described. Most which have demonstrated efficacy tend to be delivered at least once a week and typically for periods of 4 to 6 weeks before you see benefit. A number of health and social service programs, particularly in terms of responding to at-risk individuals. One example for that is the prescription for social isolation program, which has been used a lot in the UK and is now being actively used in Ontario and Canada. Social prescribing. Befriending is a common strategy that people turn to, whether it's telephone support or one-on-one volunteer visits. And it can be efficacious in housebound individuals, and certainly subjectively the individuals feel better. However, in many of the studies, it's been less effective than some of the other group interventions. And then finally, there's the category of encouraging leisure and skill development through things like art, gardening, sports, music, etc., which have all been shown to be effective. And interestingly, the use of computer and internet training, which of course has become all important for us to communicate with ourselves, colleagues, and also family members through tools like Zoom. So, emerging from this background literature and interest, in April, we were invited to deliver a webinar to talk about the issues of social isolation amongst community-dwelling older adults during and post COVID-19. We organized a webinar which was attended by over 500 different registrants, and there was a great deal of interest and number of interactive conversations that occurred during the event. We put out an invitation to that group of over 500 individuals to whether they would be interested in joining and supporting the development of a community of interest, specifically around this issue of isolation and loneliness around the COVID-19 situation we find ourselves in. There was a good amount of interest, and some 70 individuals have already signed up for this community of interest. We put out an ask to those individuals around what would be the important topics that they would like to explore more about this issue. And there were some agreement that issues around mental health, low income, rurality, people with dementia or problems with hearing and vision, LGBTQ, and Indigenous issues were of interest. So in terms of trying to respond to those interests, we're in the process now putting together a series of interactive webinars like today. We have a monthly newsletter linkages which goes out to several thousand individuals across Ontario, and we intend to focus some of the issues on these problems around social isolation. And we're actively working with a Masters of Public Health student over the summer to develop a promising practice guidebook. Basically, this will involve two separate processes. One, with the help of the existing community of interest, we've started to identify existing practices across Ontario as part of an environmental scan. We've also started to look through the internet into a number of grey literature sources, including Twitter and Google Alerts. And we started a systematic review or rapid review of the literature, which we're doing in two parts. The first part is we're going to look at the last 5 years of literature around promising practices, around managing social isolation and loneliness in older adults. And then once we've identified those promising practices, we're going to look for evidence of their current applicability and relevance within the preceding 6 months in Ontario and across Canada. So we're hoping through this process of the rapid review and environmental scan through the summer to have available by the early fall a promising practice guide that we can make available to interested groups and parties that hopefully will inform us as we move forward, both during and post COVID-19. If you're interested in signing up for the community of interest, I'd ask you to visit this website, or to email Lisa, who's our knowledge broker here at the Center for Studies in Aging and Health. We'd be happy to sign you up for the community of interest. You can elect to be just a communicating member, so to be kept updated with all new resources and strategies we're pursuing, or you yourself can become an active participant and help us in terms of building this inventory of promises and practices. Here's some of the resources that I've used in talking today. There are many, many publications on this issue, particularly in the last 5 years. And as I said, we're hoping to put that together in terms of a rapid review and making it available to people in the future. Thank you. So I'm going to stop my share and hand over to one of my colleagues.
Hello, just give me 1 second and I will be right there. Here we go. I'm hoping that everyone can see my slides. I'm sure you will tell my colleagues if you can't. Just trying to, there we go. Thank you, Dr. Puxty. A lot of what you've just shared with us will help to inform some of the things that I'm also going to discuss. I was previously a regional consultant with Elder Abuse Prevention Ontario, and this work is near and dear to my heart, as is the Lonely No More project. And you'll see how, as I go through the presentation, some of this overlaps quite nicely, and with some of Dr. Puxty's findings as well. I do want to tell you a little bit about Gateway Center for Excellence in Rural Health. Really, I'm not going to spend much time on that, but I did leave the website there for you. Lots of good information on there. I encourage you to take a visit. But mostly what I want to talk to you about today is an intervention called Lonely No More. But Gateway, the folks who are enabled this program to be developed, are a community-driven research institute, probably the only one of its kind in Canada that we've been able to uncover. And they have headquarters in Goderich, Ontario. And they house a network of rural health researchers. If you noticed at my introduction, I am their research chair for rural health coaching. So I work.
Excuse me, Sheila, sorry to interrupt, it's Christine Chan here. We just have some comments that your slides appear quite blurry. I'm wondering whether maybe if you turn off your webcam, maybe that would improve it. I'm not sure.
Okay,
sometimes...
let me get out of this then and try again. Thank you for letting me know before
It's got good information that we would love to see, and I've seen them, so I know it's worth seeing.
Okay, let me try to turn off my webcam. And then let me try this again. So I'm going to do from current slide. From current slide, come on. How's that? Is that any better?
Not really, I'm so sorry.
Okay, let's go back again and just see if, I don't know why they look clear to me on my screen. Okay, let me get out of here again.
I know, and when we did our practice run, they were clear, so.
Yeah, I'm not sure what that is about. How about if I come from this perspective? It's not full screen?
No, still not clear. Laura, do you have any ideas? I'm wondering if, since Laura has the
What I'm going to do, guys, is I will go ahead and share my screen.
Okay. Thanks, Laura. Always good to have a backup. You want me to get out?
I just booted you out.
Bye-bye.
Bear with us, everybody.
Shannon has a good idea. She suggests stop screen sharing and then share your screen again without your webcam. Yep, actually, oh, Laura.
Oh, we'll just go with Laura. She's there, and
Okay.
I'm
Thanks,
lazy.
Here we go, Sheila. Just tell me
All
when
right.
to change your slides.
Yep, go again.
Okay.
Go. Okay, let's stop here for just a minute. Thanks. So I won't spend a lot of time on this, as I said, but I did want to ground you in knowing a bit about how this project was developed and who's bringing it to community. So these are the goals for the Gateway Center of Excellence in Rural Health. Is really to, if you swing around the circle, you'll realize that what it really is about is trying to look at the disparities between rural health and urban health. We really do a lot of, we look at research that already established and try to improve education in rural communities. Really are trying to maintain positive health status in rural subpopulations, of which seniors is one. If you've done any of research into rural aging, you'll realize that rural communities are aging at and for most, there's some specific instances where this is not true, but they're aging at a more rapid rate than many urban communities. And we also realize that the out-migration piece is really affecting rural communities. So meaning that youth are leaving their homes to go find work, and that means that sometimes programs and services don't have the human resources to be established in rural communities. So I'll get you to go to the next one, Laura. So the service area for Grey, Bruce, Perth, and Huron regions for Gateway, but they are involved in research right across the country. The reason that those, well, number one, they're housed in Huron, but in these communities, in this little zone that you see the map there, large rural population, and we are lucky to be able to access renowned regional academic centers, use a lot of students in our research projects, involved communities. Communities are very engaged in what we do, lots of volunteers stepping up to learn more, and again, that large aging population. Next slide, please. I won't spend a lot of time on this. I did want you to kind of ground it in a stat coming from the National Seniors Council a couple years old now, but 1 out of every 3 seniors are socially isolated. That's what they're estimating. And again, Dr. Puxty really clearly articulated some of the risks. So we'll move forward. I do want to spend a moment on the double jeopardy that we see in rural communities. So, geographic barriers to access support's a real issue. I've included a little quote here from the Rural Ontario Institute, but really we've already mentioned out-migration, and oftentimes they don't have the infrastructure or the financial resources to look at complex needs. Definitely transportation. If you're ever doing any kind of rural investigation, you'll find that access often requires transportation. And when you think about that, what happens when an older adult can no longer drive or has access to someone who can drive for them? So that really ups the isolation quotient for rural older adults. You notice that they talk about reliance on volunteerism here, and they're kind of stating it as a negative, but the Neighbors Helping Neighbors is still very strong in many rural communities, and that's something that the Lonely No More program has been able to access and build on. Next slide, please, Laura.
Excuse me, Sheila, someone asked, is this figure for rural area or national data?
The quote that the 1 in 3, that's national data.
Thank you.
Yes, you've got the quote from where I took it, 2016 quote. It's the one before, I guess. But yeah, that's on the National Seniors Council. So let's talk specifically about the Lonely No More program and how it came to be. Our subtitle is always Rural Community Connections, and it is a program for seniors. We did an application to the Ministry of Seniors and Accessibility, back in 2018, and we were very lucky to be able to receive that funding with the goal of reducing social isolation for rural seniors across the 4 counties that Gateway serves, looking at strengthening and expanding social connections for rural seniors, improving opportunities for participation in networks that already exist, and then building new social support networks. Next slide, Laura. So we had project collaborators, and so the project, when I mentioned project, it's now gone from a project to a program, but the project was the 1-year funding that we received from the ministry, and these partners were all involved. Of course, the ministry, you'll see the Ontario government symbol there. University of Waterloo, Faculty of Science and School of Pharmacy, they were actually the lead agency on, or the lead organization on our application, and they were involved in the research and evaluation component of the pilot. Southwest Healthline also helped us with developing some education and some experiential learning around system navigation for community members and volunteers in the program. And then the It's Not Right program out of the University of Western Ontario was facilitated to community members and volunteers through Elder Abuse Prevention Ontario. So we also crossed into making sure that folks had that awareness. 2018, 2019, so here again, it's the project. When we first started, we developed a project advisory committee, and you can see they're wide and far across the four regions. Very important because they had the access to the older adults or new people on their roster that could benefit from this, as well as people wanting to volunteer. So they were very important to the project to get the word out. So I mentioned that we turned from a project to a program. You know how you'll see later in some of the evaluation that the advisors, you know, very early on, we knew that sustaining this was going to be a challenge. So when, you know, we wrapped up March 2019 with the project, but in the fall of 2019, there was a real surge from community trying to get this back. So of course, Gateway gave some in kind, and University of Waterloo covered the cost of our teleconference line to continue the program, as well as staffing. IODE and the Rotary Club stepped up with some donations, and we were lucky enough to start a partnership with Grand Bend Community Health Center, which just borders on Lambton and Huron County. So the project was moving in towards Lambton when COVID-19 hit. They were actually going to host our next volunteer education, or our community information and volunteer education day, but then that had to be canceled. So how do we reduce isolation? And we do it really through peer support. It's important to know that when we do community education, as I mentioned earlier, Neighbors Helping Neighbors is very strong in rural communities. So, you know, cultivating a caring and compassionate community isn't a hard go. People do know each other. They are worried about their neighbors. So what we really wanted to do was give them the skills to help people that they knew, and encourage community members to start to recognize some of those, you know, risk factors, and to maybe start to identify some vulnerable older adults that they hadn't thought about it in that way before. We really wanted to raise awareness on the risk factors and types of elder abuse that happen. Most people know about, you know, financial scams and things like that, but maybe not some of the more detailed information about risks. So we delivered the It's Not Right program, bystander engagement program, to the communities, and we also did that work with the Southwest Healthline around a system, a navigation experiential. So people actually got a chance to work through a case study and try to find some services within their own local area to support someone through the case study scenario. And then active listening, thanks. Active listening, one-on-one coaching. That's another piece that we really wanted this program to be empowering and not what I call a do-for type of program. We wanted this to be driven mostly by the seniors, the volunteers, and the seniors participating. So we spent some time giving the community members and the volunteers some training in having a coaching dialogue. So, you know, asking questions and trying to figure out what the older adult wants, rather than being prescriptive and telling them what would be the best for them. So throughout the education day, which was one long day, we would give this education to anyone who wanted to attend. And we would, as we went across all 4 regions, we would have between 10 and 15 on average per location. And then we would invite attendees about midway through the day to consider becoming a volunteer. And I would say out of that, you know, we always did on our promotion tell people that there was going to be that opportunity. So some people came looking to volunteer. But I would say out of that, we got between 40 and 50% of attendees who stepped up to be volunteers. Next slide now. Thanks, Laura. So how do we do this? Well, we have 2 volunteers out of the group of volunteers that are trained. And actually, beyond just a community education day, we also provided specific training and ongoing training for the volunteers. But we would take 2 volunteers and we'd match them with a group of socially isolated rural seniors. Also important to tell you that the rural senior, we'll talk about how we recruit participants, but they self-identify. Some of the folks that join the calls, really, we would not have thought of, you know, knowing the community, wouldn't have thought of them as socially isolated, but that's how they self-identified, which I think is a really important learning. Volunteers facilitate what we call elder circles of peer support over the phone, and the participants are joining via teleconference. And it's not a set agenda. It's not recreational insofar that there's any expected activities. We have had some guest speakers at the request of the participants, but collaboratively, what they're really doing is exploring, you know, their experience of aging in a rural community, what's working for them, what's not, what they need help with if there's something. They're looking for commonalities and differences to have that meaningful conversation and do some sharing. But in the meantime, volunteers who are facilitating this are paying attention to any warning signs of potential elder abuse or vulnerability. And if that's noted, then the volunteers, they can come back to program leads, or if they're feeling comfortable, they can make a call to the person who is identified as having a red flag one-on-one and see if they can have that coaching conversation. If there's resources that that person's looking for, how can we help and make sure that we reduce risk if we can. Next slide, please. So how will the Lonely No More reduce loan, and why are we using a phone? Well, I know that, you know, in Dr. Puxty's, the phone interventions were not deemed as effective, but for a rural population, it kind of works. It cuts down that mobility barrier. From transportation, no one has to drive, and nearly everybody has a phone. Internet service in some rural communities is not available. Older adults may not even have a computer, so a lot of you know, the Zoom type of things weren't going to be as accessible as just picking up a phone. Also work for our volunteers, who are oftentimes, you know, it's a peer program. So when I say peer, I mean they're either rural residents themselves, but in fact, usually they were rural older adults. So I mentioned I talk a little bit about participant recruitment. So the support, another learning is that it's very hard to identify these older adults. It's not an easy, here's the list, go after it. You know, we had to take a lot of time to uncover, and it really was what I would call a saturation point between the project and turning it into a program, where people finally, you know, got it and were starting to refer to us. But it was a tough go to identify these people. But stakeholders were the key there, as I said earlier. They provided people to come to the program, so did family members, health providers, mostly self-referrals, though that was the highest source. Only requirement is that the seniors have the phone, so that makes it quite an easy access. Next slide, please. So I did want to spend just a few minutes, because before we rolled out the program, we did an evidence review on other programs that could influence our model. And I wanted to share what those were with you, because I thought you might be interested in some of them, separate and above Lonely No More. So let's go through that list. Next slide. So the Gatekeeper program was really helpful in terms of identifying, well, we took some of their training modalities, because they were training employees in different communities to start to try to identify at-risk older adults. And, you know, you can look up the Gatekeeper program and find way more than I'm going to be able to share in this short time. But it was around getting local community to identify its own people in need of help. And that rang true to what we were attempting to do as well. So some of the education that they were using, we incorporated into ours with their blessing. So feel free to look up that model. Next one. So as I mentioned, it's not right, changing social norms of bystander on abuse of older adults. That program began in 2012 by the Center for Research and Education on Violence Against Women and Children. And it started as a pan-Canadian project, and it comes out of the University of Western Ontario. And it's really trying to engage bystanders on the issue of older adult abuse and neglect. Because oftentimes what we do is when, you know, we think that's a private matter or we don't know how to handle it, so we don't confront it. So it's really about having a conversation. And there's skills within this training program about how to have that conversation. So we, again, delivered this education to the community, and those folks who turned into volunteers with us had this training as well. Next slide, please. And I'm not going to spend much about this because after I'm finished today, Laura will be talking specifically about the Senior Centers Without Walls. So that was an impetus for us to start to think about a gateway, innovative ways to deliver the program. You know, they were managing to be able to very successfully deliver a program, you know, without having people go into the home or alternately have to drive to a location. So that innovative outreach program really got us excited about perhaps trying it ourselves through telephone delivery. Next slide. And then this is an interesting program that really kind of addresses some of the issues that Dr. Puxty talked about. You know, an increased use of emergency rooms and, you know, needing that kind of system navigation or that referral. So this program comes out of the US at South Carolina, and they train volunteers to really help people who were being discharged find whatever services and supports they needed within community. So that model rang true too, and that's the reason for the health coaching piece of the Lonely No More and that system navigation piece. It's interesting, the last point is that, you know, the health coaches themselves, most of whom were retired, reported they experienced positive impacts such as role satisfaction offering these types of services. And we seconded that when we did our evaluation, that the community members and the volunteers who took the training really felt that the resources they were provided were resources they hadn't had access to before, and that would make them stronger citizens in their community. So we can agree with that. So the last program that we looked at and we used some of their information was Saging International, and they're a community of elders and elders to be who are looking at new ways of aging. So they promoted the creation of wisdom circles and really allowed people to come together on common interests and maintain social connections with other like-minded persons. But they really focused on, you know, aging and what it felt like to age and what was needed now. They had some great topics to inspire conversation, some great questions that we put into a book. We'll go to the next slide. That we gave all our volunteers. It's an Elder Circle guidebook. We say draft on it. We continue to say draft to this day, simply because it's a living, breathing, dynamic document. As we continue to deliver, we learn more as we go. So in this book, it has lots of different topics. It talks about troubleshooting the teleconference line. So we've armed our volunteers with some resources for hands-on delivery. Next slide. As well as we put policies and procedures into place that we feel are very important to keeping both the volunteers and the participants safe. Of course, they receive welcome packages, and participants as well as volunteers are asked to sign a confidentiality agreement. When you're doing virtual programming on telephone, you know, Mr. Bill Smith might be a 34-year-old fraud scammer, and we don't know because we haven't met that person. It's a little different in rural communities. Oftentimes, you know, you may know people, but we definitely wanted people not to be giving their address or their personal information across the teleconferencing waves. We really wanted to be able to make those connections happen, which they did, but offline. So both the volunteers and participants understood the confidentiality was important, and then volunteers on top of that signed a conflict of interest agreement so that they wouldn't, you know, attempt to do sales of any kind to the participants. We also developed activity logs, and when the program went into when the project turned to a program, we used SurveyMonkey. So volunteers would complete and submit this activity log after each elder circle. And there was a section there for the one-to-one coaching follow-up if they had to do that. That allowed us to kind of collect some really good data when it was a project, but also just to see how it was going and if any of the volunteers were struggling, or if, what topics were being discussed. So very valuable. Evaluation, both in the research component and the supplemental evaluation that we just concluded, volunteers and participants were asked to sign consent to participate in that when we're collecting their data. So we'll go to the next slide, please. So this is some of the information that we were able to glean from the research and evaluation. I thought it was a really unique program that was really focusing on peer-to-peer support, which is amazing. It leads to that level of connectivity and compassion and a sense of belonging that we're looking for. And that was actually one of our program advisors that said that. Again, the peer support, the volunteer in the second paragraph kind of talks about that benefit for peer support. And then one of our participants said, the person who might start coming to the point of feeling nobody cares about me with those things, meaning weekly calls, you got the feeling, oh, there is somebody that cares about you. So that puts the nail on the head. That is definitely what we wanted to achieve. We also realized that the project generated a number of positive impacts. One gentleman, a participant, we saw him become more involved in the community and begin to socialize more. I feel that we really had a positive impact. And there's another one from a participant right below that. All of a sudden, I had a chance to play and sing a song and shared that song with people on the phone, knowing that someone listened to it and really enjoyed that too. So you can kind of see the interactions are not stagnant. They're group driven, and this is definitely an empowerment model. Next slide. I must say that the advisor here that's talking in the first quote is talking about sustainability, which is a struggle for this program because it was a pilot, and in the not-for-profit sector, often I lose hope that short-term projects will sustain and we engage vulnerable people and then we're not able to continue to support them, or especially when you think you're dealing with people in isolation and seniors. I think from the beginning, it's been identified as a risk. It's being part of conversation, which gives me hope. So we continue to look at partnerships and collaboration to keep this specific program going. And one of our volunteers wanted more training time. So you can see that we are getting recommendations in how to improve the project as well. So I don't know, Laura, how we're going to do the video. Do you want me just to try?
We won't be able to do it. It's not loaded on my computer. So we'll make it available to participants through the chat box.
All right. Okay, I did have just to wrap up, I did have a video here for you that CTV did up for us with one of our volunteers and a participant. It's a really good watch. It's only like 4 minutes long, if that, but it really does give you an encapsulation of the benefits and the meaningfulness of this program. So thank you for letting me share a little bit about it.
Thank you, Sheila. If we can move on to Laura Ward.
Hi, everyone. I'll just start to share my screen there with you all. And I'll get my slideshow started. Please do let me know if it's not clear or if there's any issues, and I will try to address them. So thank you so much for this opportunity. My name is Laura Ward, and I'm the Senior Center Without Walls Provincial Lead at the Good Companion Senior Center, and I work in partnership with the OACAO, the Older Adult Centers Association of Ontario. So I feel, like I said, fortunate to be here. Thank you for this opportunity. Thanks to the Elder Abuse Prevention of Ontario for this. And bonjour tout le monde, je parle français aussi. Ma présentation est en anglais, mais je suis heureuse de répondre à vos questions plus tard en français. So today I'm going to tell you a bit about what is a Senior Center Without Walls, how does it work, and it sounds like you might have gotten a bit of a sense from that presentation from Sheila, and that was very interesting. Thank you so much for sharing that, and thank you to Dr. Puxi too for all of that important information. It's also related. So I'll tell you a bit about the Senior Centers Without Walls, and I'll talk about how they have grown how our program has spread across the province and how we've kind of rapidly continued this expansion during this challenging time with so many people at home. So what is a senior center without walls? I'm just going to quickly go through a who, what, where, when, why of senior centers without walls. And I can speak specifically to the program in Ottawa that I've been a part of for the past 2 years. As you will learn through my presentation, many more senior centers without walls are popping up across Ontario. So this is a bit of a general overview of what is a senior center without walls. So who joins this program? It's for older adults or seniors 50 and over. And again, that can be specific to the organization. So in Ottawa, our program is for seniors 55 and over and adults who identify as living with disabilities. What is the program? So it's those people who participate become this diverse community of people who connect with each other by telephone for group activities and also informative and interactive presentations. So the groups are very diverse. These are people coming from all different places with different stories, different experiences, coming together on the phone and getting to know each other as a group. It does develop quite quickly into a community, and new members of the community are welcomed in from the older members who are a bit more comfortable and familiar with the way that it works. And I'll show you in the next slide some of the different activities that we offer in Ottawa and that are being offered in some of the other new centers, and a sampling of some of the presentations. But there's a lot that can be done over the phone, as you saw from the past presentation as well. Some amazing connections can be made and some wonderful information can be shared. So where is a senior center without walls? So it will be anywhere and everywhere that the participants are. So anywhere there is a phone, again, it's a phone-based program. We've stuck to this model because it is very accessible. The telephone is something that many people have access to, and internet can be challenging. Maybe people don't feel comfortable with the technology, or there's not good internet access where you live. So the phone is a pretty good kind of unifying piece of technology. And all across Ontario, so I'll get into that a little bit more, but definitely these centers are across Ontario, and more are starting up every day as we speak. So it's very exciting. When does it happen? So there are sessions usually about 30 to 60 minutes in length, offered regularly throughout the week. Again, it depends on the center that is in the area that you're in, but usually Monday through Friday and consistently throughout the week. So there's a little note there to check local programming schedules for details, and I'll have a bit more information about that closer to the end. And why do we offer this program? Well, it may seem obvious from these past two presentations that you've heard, and from what we know about isolation and loneliness, but just here I indicated it's to offer an inclusive and safe, inviting space for the participants as well as the facilitators and presenters to listen and learn and be heard. And this in turn increases the social connectedness and well-being of all of the participants on the phone, and again of the facilitators, volunteers who support our program, and the presenters.
Laura, excuse me, this is Christine Chan. This is a question just quickly. Is there Nikki would like to know, is the participant required to call in, or will they be called?
That's an excellent question. So using the platform that we use, it's a very accessible platform. So some participants do call in, so they have a choice. They can access the phone by calling in independently, the phone conference by calling in independently, or they can pre-register for programs, and the facilitator can call out to them at the beginning. And that can happen in one of two methods. I won't get into the details because we don't have too much time for it, but that could be a direct sidebar conversation, so the facilitator could speak directly to that person, then connect them into the call, or they could get an automated call out at the time of the beginning of the program.
Thank you.
Thank you for that. So I'm just going to move on to the next slide. So as I mentioned, I just wanted to show you, just to give you a sense of some of the programs that we've had. This was from our winter calendar prior to the closure for COVID, but the programming continues to be wonderful. So we have lots of presentations that we have wonderful partnerships. As you can see here, we had a presenter from Osteoporosis Canada. We had an excellent session on laughter yoga, where we were all laughing and together and feeling the benefits of that laughter, which is pretty amazing. I don't know if any of you have participated, but laughter yoga is a great thing. We do a weekly mindfulness practice on the phone. We had a mental health series offered through Ottawa Public Health. And then this is a sampling of some of our regular interactive programs. And again, a lot of these have been picked up by other Senior Centres Without Walls across Ontario for interactive activities, so table topics, categories. We listen to short stories and learn about biographies of some important people. And there's always a chance for discussion. And I just want to note here that our participants are very involved in developing these program guides. We do encourage other Senior Centres Without Walls as well to reach out to their participants and get feedback and suggestions for topics, because it is a program built for them. So there's a lot of interaction. And we've had speakers from Elder Abuse Prevention Ontario as well come in and talk to our participants. So this is a really, really great way to connect. But I also want to emphasize that these are group conversations, but part of our program is connecting individually with these participants as well. So there's always the opportunity for referral if you notice that there's some services, or if people reach out for additional services, contact information from some of our presenters. Our presenters are always willing to share their information. So it's a great way to link people with services as well. So now I'm going to get into the expansion. So as I mentioned, we have been able to expand across Ontario, and we started this expansion in 2018. So the Good Companions received a Seniors Community Grant from the Ministry for Seniors and Accessibility to develop a Senior Centre Without Walls toolkit. So basically a how to start your own Senior Centre Without Walls. And we were able to pilot this project across the province. By August of 2019, 8 new Senior Centres Without Walls had continued and successfully launched their programs. And as a result, more and more seniors and adults with disabilities across Ontario became able to access these programs in their communities. And as you will see in a subsequent slide, the ministry continues to show great support and dedication to addressing the needs of socially isolated seniors. Now, as we've all experienced, the impact of COVID-19 is quite profound. A lot of people have had to really adjust their lifestyles and how they work, and it has had a profound impact on our seniors that were able to access services and connect with each other in person in their centers. So I'm just going to highlight a bit of the impact that COVID-19 has had on communities that I've seen, and the kind of overwhelming response of communities and individuals during this time. So senior centers senior centers in general across the province, as I mentioned, and around the world have had to close their doors due to this pandemic. And this in turn meant that some of those existing Senior Centres Without Walls that had started were no longer able to continue offering programs. That, kind of in the shuffle of people trying to keep things going and connect with their participants. So almost all non-essential staff in these senior centers have begun working from home, and these strong socially connected communities of people have been dispersed. And this has resulted in an increase in isolation, loneliness, and as we saw earlier, and as we, have become quite aware in mainstream media, that isolation and loneliness have some very detrimental effects on our mental and physical and spiritual and emotional health. So people are seeking some way to feel connected and to offer help. We had a lot of people reach out to us knowing that we had this program already, tried to join up to our program. Obviously, we welcomed them. And we also had a lot of people offering help. So volunteers, new people who wanted to become volunteers. And I got a ton of emails and interest in learning about our program, and people wanting to contribute, become presenters, support our participants, but also to spread the word and expand into other communities and possibly start up their own programs. So initially at the Good Companions, we were able to expand our program. I did some training for my colleagues, and our adult day program was able to start a day program without walls. And we have a large Chinese community, so my colleague was able to start a Mandarin Senior Center Without Walls, and then she partnered with another agency nearby, and they increased their offerings to include Cantonese. So a lot of programs started up just kind of initially, just organically, and we were able to spread throughout Ottawa and the region. And then I'm gonna click again here. Since mid-March, around the same time, following the closure of the centers, the Good Companion Senior Center was able to partner with the Older Adult Centers Association of Ontario, and to provide some information in an introductory webinar, and also small group training sessions to explain our platform and how we run our phone-based programs to 80 centers across Ontario. And many of those are starting to deliver their own Senior Centers Without Walls programming in their communities. And the community-based program is very important. I was going to mention this earlier, but I just remembered now. But you know, in order to do those links to help people get connected to services in their communities, to help feel connected to the people that are around them. So, and Ontario is pretty big in terms of population and communities in different areas. So we've really begun to expand, and it's with funding support from the Ministry for Seniors and Accessibility that we were able to do this. So we've begun to also share resources. So our resources from our program at the Good Companions, and also other centers that are starting up with their own Senior Centers Without Walls, we're starting to exchange information. I'm helping different centers connect with each other if they're offering similar programming. So we have a lot of centers who are offering English as a second language programming, or programming in other languages, as well as you know, different kinds of activities, and they're just sharing ideas. And I was thinking about the exercise one. People are trying to implement some kind of safe exercise over the phone. There's lots of different things that can be done, and that are being done in these different centers across the province. So we're providing this ongoing training sessions and kind of collaboration with this whole network of new Senior Centers Without Walls. And this has all been possible through this partnership from the Good Companions Senior Center and the OACAO, and with the support of the ministry. And I'm very happy to be a part of it. I'm happy to share this information with you today. I don't like to just talk about our program exclusively, because there are so many great other phone-based programs out there. So I just wanted to include this slide, and I just, you know, to make sure that I don't take up too much time, I won't go through everything. But if there's anything on there that you have questions about, please feel free to kind of look into it more, or reach out to me after this webinar. There's some great programs out there, and there's also some great resource lists that are coming out from lots of different sources. So I'd be happy to kind of expand this slide, or share resource lists that if anyone has any information they want to share with me. But I do like to include that for everyone to see. Now I just want to let you know, if you want to find more information about Senior Centers Without Walls, to see if there's one close to you, or to find out more information about starting one in your area, you can reach out to Lena Zita, who's on this call now. And hi, Lena, and we've got her contact information up there from the OACAO. And I believe my contact information will also be shared at the end, so you can reach out to me with any questions you have as well. And I'd be happy to help and answer them as best I can. Thank you very much. Merci beaucoup. Here's a little painting from one of our participants in Ottawa just to have a look at. And I will pass it on to the last group of presenters now. Thank you for listening.
Thank you so much, Laura.
Great, thank you. I'm just going to try to share my slides. So let me know if you have any issues seeing the slides, but hopefully everything is going smoothly. And okay, so a brief introduction of myself. So my name is Gia. I am a medical student with the Schulich School of Medicine and Dentistry at the University of Western Ontario. I'm joined by my two esteemed colleagues, Erica and Karina, and together we'll be speaking about the Student Senior Isolation Prevention Partnership, which is an initiative started by medical students to help seniors to prevent social isolation. So a bit of background of SIP. The full name is a mouthful, so we do abbreviate it to SIP. It started as a collaboration between University of Toronto medical students and the family health team at the University Health Network, Toronto Western Hospital, located in Toronto. So originally, I believe the program started about a year ago, and at the time, we were having medical students visiting seniors that have been referred who are struggling with issues of social isolation. And in response to COVID, obviously the in-person visit can no longer happen anymore. And so in response to COVID and also the increasing risk of loneliness, I think medical students across the country felt a collective social responsibility and the need to volunteer and also to help vulnerable populations, in this specific case, seniors who are living in isolation. So SIP expanded and became a national initiative with 12 plus medical school chapters across the country. And really our mission, just as the mission with so many programs that have been previously mentioned, is to mitigate social isolation in older adults by providing social connections and also personal empowerment. And we hope to support older adults, not just in communities, but also in long-term care homes through this program. So specifically, what do we do? So we pair a medical student volunteers, and in this case, in our chapter from Schulich School of Medicine and Dentistry, and we have two campuses, both in London and Windsor. So we pair student volunteers from both campuses with socially isolated older adults, and volunteers check in and chat with the referred older adults through weekly phone calls to provide social connection. So one of the things I do want to highlight about our program is that many of our volunteers speak and are able to provide support in other languages. So later on, you will hear from my colleague Karina just the range of languages that we have available to offer. And older adults can be referred through either a member of their healthcare team or one of their healthcare coordinators or relevant health organizations to the program. So for example, we've had referrals from recreational managers of long-term care homes to our program as well.
Okay, so my name's Erica, and I'm also a medical student. And I'm going to walk you through our recruitment, volunteer matching, and follow-up process. So patient recruitment is our first step. We reach out directly to physicians and to long-term care homes to let them know about our program. And we also welcome healthcare providers and long-term care homes to share our information with other providers that they think might be interested so that they can reach out to us. Interested healthcare providers or long-term care homes then email us a list of patients with phone numbers and the patient's preferred language to one of our secure hospital emails. And then next, one of us makes a first phone call to obtain consent from the senior and enroll them in the program if they're interested. And then lastly, we match the senior with a student volunteer based primarily on language requirements. Alternatively, if the referring provider has explicitly told us that they already have the patient's consent, we'll simply have the senior match directly with their assigned volunteer to make the first call. We also keep up with our volunteers via weekly check-ins. This is done primarily to ensure that the phone calls are occurring regularly, so on a weekly basis as planned. And we also do this to allow volunteers to report any concerns back to us, the coordinators. And then either we can deal with the concerns ourselves, or with consent of the seniors, we may escalate the concerns to the referring physician or long-term care homes. Next slide. You ready? Okay, and next I'm going to talk about safety for older adults in the program. So the first point is that we only have medical student volunteers, and this is important to us from a safety perspective because every medical student has an up-to-date vulnerable sector check with the police. And also every medical student from the beginning has some basic training in confidentiality because it is quite an important part of our schooling. And then additionally, we also have every student sign a confidentiality agreement when they're matched to a senior. Another thing for safety, students do not provide any medical advice and are instructed to refer patients either to telehealth or to phone their GP or geriatrician if they feel they need medical advice. And then lastly, everybody referred to our program has some primary person we can contact if we have any concerns. For example, their GP, geriatrician, or somebody working at their long-term care home if we feel we run into something or our volunteers run into something that is over our heads. So that's important to us that we don't actually take self-referrals. We need somebody sort of referring to us that we can contact if there are concerns. Next slide.
So, hi everyone, my name is Karina. I'm also a medical student. I'm going to start by talking about the reach of our program, which is actually quite extensive in terms of language and location. So as you can see, our volunteers speak a wide variety of languages, and we're continuously recruiting volunteers. And this is primarily so that we can support seniors in the community for whom English may not be their first language. In terms of location, our executive team is based in London and Windsor. However, we do cover the Southwestern Ontario region, and the beauty of our program really is that the connection between students and the seniors is made by phone, so distance is not really an obstacle when we're forming these partnerships. And when it comes to recruitment, as already mentioned, we are working with long-term care homes both in Windsor and in London, and we also have seniors referred by family physicians, geriatricians, personal support workers, and other healthcare professionals. So we started running our program at the beginning of May, so it's been about a month and a half now. Since then, we've recruited over 95 volunteers, and we have over 30 partnerships running at this time. Our volunteers also keep track of their hours, and so we know that we've amassed over 30 hours of calls at this point. And it's our volunteers and the seniors that they call who really determine the schedule and the timing of their phone calls. So some people call multiple times a week, some people call several times a month. So it's really flexible in terms of scheduling for both parties. So even though we started as a COVID initiative, we're really pleased to see that the students and seniors are really forming very personal connections and friendships. And it becomes less so a conversation about a pandemic and rather just a friendly check-in once a week. So as you can see from some of our very touching anecdotes that we've gotten from volunteers and the referring healthcare providers, students and seniors connect on their backgrounds, their hobbies, they learn from their conversations and from each other. And so even though we do have protocols in place that mandate that our volunteers make sure that the seniors are getting their basic necessities met, that they know of the current safety guidelines, that they have their basic questions about the pandemic answered as well. Primarily, it becomes more so a friendly conversation and a time for social support.
So to finish up the presentation, I just want to briefly touch on what we plan to do for the next stage. So as Karina mentioned, I think we started off with the sense that this partnership will be more of a short-term COVID response type of program. But in reality, we see that one, COVID is sort of dragging on longer than perhaps any of us could have foreseen. And right now, September is looking a bit grim as well. So we do want to transition into a long-term initiative and organization. And we also have heard so much positive feedback from both referral sources and also from our volunteers. So we do want to continue to run this in the long term. So in the long term, at a local level, we do wish to become an official student-run extracurricular program affiliated with the Schulich School of Medicine and Dentistry. That would just offer us more resources and also more support from the faculty members as well in terms of our program. At a national level, as I mentioned, we do have established chapters across 12 medical schools across the country. So we do want to become an official national organization as well. And the purpose is to standardize our protocols, our forms, our recruitment and referral processes so that everything can be centralized and legitimized, so to speak. I want to leave off with a bit of contact information and also more information regarding the SIP organization. So at the top, I put down our Western Ontario chapter's email. So any referrals can be made through those emails, and we can talk more in terms of details of where to send the referring information. And if you're interested, feel free to check out our website, which also gives you contact information about the other chapters of SIP as well. And I just want to finish off, thanking the Elder Abuse Prevention Ontario for inviting us today here to make the presentation. It has been a real honor for us medical students to be speaking over here, and it's been quite amazing to hear all the programs that different organizations have been running. And if there's any questions, we would be happy to answer them at the end.
Thank you so much for that very fascinating presentation. It's wonderful to hear of all of the initiatives going across the province currently. I do want to share with our attendees today, Laura Ward did highlight it, so I do need to thank you, Laura, for highlighting our senior safety line. It is available 24 hours a day, 7 days a week. And a few highlights is that the phone line is managed by experienced staff, and they offer services in over 150 languages. So I do encourage anyone working with seniors to give this number out. It's 1-866-299-1011. And of course, I can't end a webinar without promoting that we are on social media. We encourage everyone to follow us. We do have upcoming webinars. We actually do have another one being hosted by my colleague tomorrow, and we have a few others next week. So if you follow us on Twitter, Facebook, or LinkedIn, you will see all of the excellent initiatives that are going on across the province. And again, here's my information, Laura Proctor, and my email address that you can see there. And we'll open it up now. If I could pass it over to my colleague, Christine. It is question and answer time, so our panelist is ready to answer some key questions.
Wonderful. We've had really very good questions from the group today. I think everyone knows we've had about 180 people online today. So the first two questions are for Dr. Puxty. What shall we do since he's not there, Laura?
If we could hold them, and we'll email them to him for follow-up at a later time.
So the questions from Jen and Kathleen, we will email to Dr. Puxty. The next series of questions are for Sheila. Sheila, yes. From Christine Comtois. Has Public Health Ontario offered financial assistance or the federal government United Way in COVID-19?
We're actually looking into a grant application now, and jointly actually with OACAO and Senior Centers Without Walls. We're just starting to investigate some kind of collaboration here. But yes, we are definitely looking at other funding sources. Ontario Public Health hasn't offered to us yet. Because we're, kind of a regional model, although we've had interest from Oxford County, Elgin County, and now Lambton, we're kind of spreading, but we've kept it kind of on the down low until today. So I expect to hear a lot more. And then I think there'll be more support from, provincially. So thanks for suggesting it, and we're on to applications that are due in July.
The next question number 5, which I have officially put on in the chat box for anyone who wants to read it. Question number 5, also from Christine Comtois. How do we become a coach, Sheila? How do we become a coach?
Yeah, so the coaching piece is I'm a national, well, US, because we don't have it in Canada, certified board of medicine coach. So I've taken those skills and compiled it for volunteer training. You know what, if you want to take my contact information, we can certainly talk about that offline. There are coaching training programs all over the place, but those are actually not designed just to give the basic dialogue types of skills. So feel free to reach out to me after this. I know that my contact information will be posted and we can talk about it. There may be some opportunities coming in the near future for some peer support coaching training. We have got an application in, Gateway's put an application in for that to occur, because as we were delivering our volunteer education, it was all done in person, which of course can't happen anymore. So we're needing to make that shift to e-learning and to Zoom types of education. So we're working with a foundation that might be able to support us to give this kind of training more broadly. So again, just reach out to me if those are things of interest to you, and I'll try to figure out a way to get you the skills.
Thank you. So looking at the Zoom chat box, I'm moving to question 9 so that we give other speakers a chance. And then if we have time, we'll go back to the other questions for Sheila. So Laura, number 9 from Lole, is there a senior center without walls in Windsor, Ontario?
There is a senior center without walls in Windsor. I don't have the contact information handy, but please share Lena's contact information that was in my slide. Lena is kind of the best person to link to the new existing senior centers without walls. So the answer is yes.
Great. Okay, and then Christine has asked, she said, funding already in place. How can one start a center in Ottawa for French-speaking elders? I can start one because I'm already an advocate. Also, I'm starting webinar chair exercise with my participants in June. Maybe I can do this with a good companion.
Okay, so there is already a French language senior center without walls that has started up in Ottawa. And Christine, you can reach out to me directly about that, and I will help provide you with more information. We are beginning to work towards offering webinar type exercise programs at the Good Companions as well, and I'd be happy to also link you with my colleague Anna, who's working on that initiative, so you can possibly work together about that. My expertise is more the phone-based programming, but I'm happy to connect you with people who are doing similar work, and so you can share ideas and tips with each other on that one. But in terms of kind of expanding the French program, I'd love to link you with them, because possibly you'd be able to help them get more participants and also help work together to expand that program. It's new.
And Kim has also just chimed in to say that Lena will have the contact details as to the Windsor contact, okay? Back to Sheila. Okay, we are going back to question number 6 from Gail. Gail asks, do any of the persons presenting ever do training to individual groups, Sheila?
That could be arranged, of course, yeah. Elder Abuse Prevention Ontario definitely does training for organizations specifically. I did a lot of that when I was a regional consultant, so I know that's an agency, one of the, some of that, if those were the issues that you were interested in having, education on that is available. And yeah, I know that I will support an agency if they need specific training. So again, I just suggest you reach out to me because I need more information.
And Jen Bennett-Pond, this is question 7. She said, yes, she was wondering about this too, whether there are cross-collaboration or consultation opportunities for other senior serving places in Ontario.
Most definitely. Again, please take my contact information and reach out. I don't know how that's working for Laura and SIP though. Did you want to weigh in on that, ladies?
Yeah, in terms of other presentations, again, I direct you to Lena, because Lena is working on our next webinar and kind of introductory webinar about the Senior Center Without Walls program. So definitely could provide you with more information about when the OACAO will be offering that. Yeah, so definitely reach out to Lena for more information about upcoming presentations.
And then Laura, we have some comments en français from Joanne, and you can read it on the chat box. She's very happy that you speak French. And Marta is actually online. Marta Hayek, who is Elder Abuse Prevention Ontario's Executive Director. She's put in the chat box that EAPO, we are also partnering with FARFO around similar initiatives to expand programs to the Francophone community across Ontario. Marta, if you want to come on, let me know. Otherwise, we have your comment here noted.
If I can encourage any of our attendees today to reach out to us, Elder Abuse Prevention Ontario, through our website. You can request training through our contact form, whether it be your training needs in English or French, reach out to us and we'll be sure to book a training with your agency. Christine, just being cognizant of time, why don't we do one last Q&A and then we'll follow up with all the other Q&As via email.
So we've actually answered all of them except the ones for Dr. Paxti.
Okay.
So we're done with all of the many comments about whether we can get a copy of the slides and the web recording, which you've already said will be available on our EAPO website.
Wonderful. So I just want to thank everyone this afternoon for attending. Please follow us on social media, check out our website. Within 24 hours, we'll be posting the recording of the webinar. And again, thank you so much. And this is the end of our webinar series for today. Take care, everyone, and have a good day.
Thank you.
Bye-bye.
Thank you.
Bye.
Be well.